Hello, my name is Timothy W. Andrews. I'm a first year student in the Doctor of Athletic Training program at Indiana State University. And today I will be talking about ACL injury disablement model and its relationship with prevention strategies. So, when I first was thinking about all these concepts, I had kind of to think myself about base them off a case. So I think that's the easiest way to kind of think about it and apply the concepts to a real life situation. So our case study is a female 45-year-old alpine ski coach. She has one child, and she first tore her left ACL while ski racing at the age of 20. This isn't a real case. It's kind of a real case. It's based off of kind of a compiled bunch of different cases coming together of patients that I've worked with. Just because I don't know all of the facts and details surrounding a person from what happened when she was 20. So I'm kind of compiling things together. But just to have an idea, I think it's a pretty realistic situation. So at the age of 45, since the patient's first ACL surgery, she's had 3 other ACL reconstructions, 2 for her left knee, 1 for her right knee. She retired from ski racing at the age of 27. She has 1 meniscus repair for her right knee, and then also she was recently diagnosed with osteoarthritis in her left knee. Outside of skiing, also enjoys cycling, mountain biking, hiking, climbing, and sailing. So basically doing a lot of things outside. That's what this patient really likes to do. She also likes to do a lot of gardening and home improvement projects. Overall, very active individual. So now we're going to talk about disablement models. So with a disablement model, there's kind of there's multiple different types of disablement models, but today we're going to be using this one, which is basically looking at 5 different parts of disablement. So first is looking at origin, which is like the pathology, the specific health condition, kind of like what's happening at the microscopic level, what's happening to the cells. Then we're going to talk about the organ level, which is a little bit broader, which is kind of like what's happening at the bigger structures, the muscles, the bones, the joints, what's the impairment, what's the dysfunction, and then from there we goes on to the person level, which is looking at functional limitations, task performances, so like, for instance, like range of motion, being able to walk, being able to move, do things, be able to interact with one's environment. That's a very important part of life. Next is societal, so kind of your role in society and how that disability relates to and affects one's role in society and the ability to participate in that. Then next is the environmental, and basically is the social limitations involved with the disability and its effect on one's social situations. So as we discuss prevention, it's kind of multiple key parts. But first we're going to talk about non-modifiable risk factors and modifiable risk factors. So both are important to understand. Obviously, non-modifiable risk factors are things that you can't really change or things that are really difficult to change. And modifiable risk factors are things that can be manipulated and changed without a lot of evasion. So a lot of them are very similar to each other, but they're also different. So when it involves environmental, such as a playing situation, a play in a game. We're looking at the opponent's behavior. Those are things that can't really be changed, or you can't influence someone else's opponent's behavior and the fact that they might push you over or whatever. Anatomical things such as tibial slope angle, notch size, those things, they can be adjusted, but that is a serious surgical intervention in order to change those things. And then there's hormonal things like the menstrual cycle. Once again, there can be interventions, but it's harder to change your hormonal menstrual cycle, along with its relationship with other hormones. And other things like demographic, like your age, family history, genetics, those things have key parts in influencing and has a relationship with risk factors. However, most of those things cannot be adjusted. So now we're looking at modifiable risk factors, such as the environment, what people have on their feet, what they're using, the playing surface, other anatomical things that can be modified, which are like foot pronation, body composition, kind of other like muscles, that sort of stuff, and then neuromuscular muscle, which is like muscle strength, muscle activation patterns. So those things can be adjusted and worked on. So a lot of prevention research, especially when it comes to sports injuries, looks at adjusting for and intervening with neuromuscular issues. And then once again, hormonal, some parts can be adjusted and modified. So then now we're looking at internal and external risk factors in relationship to prevention. So internal or intrinsic is about what's happening in your body, in your body, or around it. So that's related to like age, sex, having an injury previously, muscle strength, fitness, body composition, anatomy, alignment, that like endochondral notch width, which is big when we talk about ACL injuries, skill level, sport technique, postural stability. If you look at different levels of sport participation, you can kind of easily see the differences. If you look at a group of 12-year-old soccer players versus like a Premier League team, there's a big difference. One thing is, postural stability, the younger kids fall down a lot more. So just one thing to think about when we talk about risk factors is just skill level and ability, along with age and a bunch of other different things. And so a lot of those things, once again, you got to look at modifiable and non-modifiable. So, fitness, body composition, skill level, those things are modifiable, and the other parts are non-modifiable. And then external or extrinsic are things that are happening outside the body, but play a critical role in risk factors. So those would be other humans and teammates, or opponents, people falling on one another in sport, protective equipment, helmets, or padding, those types of things. Sometimes they're meant to help, but sometimes they can be harmful, or they can, add weight and change biomechanics. Sports equipment like skis, and those have act on a lot of forces, changing your body biomechanics. Another key thing is, with the weather, environment, the playing surface, temperature, snow and ice, those types of things can all play important roles in creating risk factors. So most prevention strategies are kind of looking around 3 different categories: primary, secondary, and tertiary. So primary prevention strategies focus on healthy people, and tries to help those healthy people avoid pathological processes. Helps them to reduce susceptibility, reduce exposure to injury and illness mechanisms, or reduce behaviors, environmental risk factors. So that'll be like high-risk behaviors, trying to help people reduce those people, or anything that's reducing the risk of illness, injury, or disability. So example would be smoking education in school. That's helping students, understand and educate about the risks of smoking and its effect on future health-related quality of life. So next we'll talk about is the secondary, which is about early detection and treatment of people with earlier asymptomatic diseases. Then it addresses reducing the risk factors or education, counseling, social interventions. Sometimes these interventions can't cure specific pathology, or at the very least it can slow the progression of the pathology. So basically just early screening, looking at the problems, and then trying to address the situation to either prevent it from getting worse or prevent it from ever being an issue whatsoever. So an example of this would be of like spinal screening in children. Next is tertiary, which is kind of after the condition has already been found. It's the measures try to reduce the progression of the condition and prevent or limit the additional impairment, functional limitation, and disability. Interventions for a person can be on just them directly, their environment, or the society. This includes rehabilitation by helping the person with a functional limitation or disability improve their health-related quality of life. So this is one area that I work in with rehabilitation as an athletic trainer, trying to help people improve their health-related quality of life. Also can not only address the person, but also their physical and social environment that create obstacles that limit a person's autonomy. So giving people the ability and adjusting for societal issues that restrict people from having their freedom. So primary, secondary, and tertiary prevention strategies. Try and remember those as we go forward. So next we're going to talk about a model for sports injury etiology, which is adapted from the MEWISE model. So basically you have things that are like internal risk factors that we've already talked about, which predispose the athlete to a potential injury. Then in combination with the external and exposure to an external risk factor, such as other humans, equipment, or the environment, leads the athlete to be susceptible. Then there is a inciting event, such as a fall, something happens, a playing situation, a weird movement, and then that causes the injury. I just want to talk a little bit about research, and so we have this framework. So we're going to talk about the TRIP method of research, which is TRIP stands for Translating Research into Prevention Practice. It's kind of a new model for how to effectively use prevention and research together to help to prevent diseases and injuries. So there's 6 steps which involve injury surveillance, etiology of the injuries, developing preventative measures, then laboratory or ideal conditions testing. Then you kind of take those laboratory studies and try and make them realistic so that they can be applied in real-world situations. And then the last step is looking at the effectiveness and making adjustments for that preventative measure to figure out what works and what doesn't work. So this strategy kind of takes into account the feasibility of implementation. So as we're looking at research and trying to come up with prevention strategies, we need to look at these 6 steps to kind of understand what steps we need to take and what information we need to collect. So typical prevention methods for injuries involve, screening. In the past, people have adjusted sport equipment or they've changed rules in sport to kind of make things safer. Other interventions can include like strength training, dynamic warm-up. There's a lot of research is getting more and more about how these things relate to injuries. So specifically, when we're talking about prevention programs for ACL injuries, luckily, I guess ACL injuries have a lot of literature behind them, and it's a big focus for trying to prevent these injuries, as they do have such a large effect on people's health-related quality of life. So typical areas have addressed neuromuscular deficits, biomechanical problems, dynamic loading. So these things would be like, landing from a jump, just in general movements, knee biomechanics, those types of things. And then movement, how your movement variability is, the muscle strength, kind of fatigue over time and exertion, and how that is related to ACL injuries. And then, like I said, the alignment, biomechanics, landing from a jump, and during cutting. So screening methods for ACL injuries, they're still in development. We're kind of, more and more research is being done on a daily basis. But some mild strength things to kind of consider are if there is an increase in knee extension, increase in joint laxity, or differences in knee abduction. Those things are kind of some basic things to look at as possibilities for higher risk people of ACL injuries. There's been a couple of programs that have developed, such as the landing error scoring system, which looked at video recording of people landing from a jump, and seeing if their landing pattern, if there's a relationship with ACL injuries, and then trying to create an intervention around that to prevent those. So that and the STAR excursion balance test, jump ACL test are all kind of screening tools that more people are using for ACL injuries. So next we're going to talk about specific risk factors for ACL injuries. So we've kind of already talked a little bit about basic categories for risk factors, modifiable risk factors, and non-modifiable risk factors. So this table is taken from several consensus statements to try and create an understanding of what the risk factors are. So we include environmental risk factors, such as like footwear, playing surface, and then anatomical issues, such as foot pronation, body composition, BMI and its relationship. Those things can be adjusted. Neuromuscular issues and deficits such as muscle strength, muscle stiffness, muscle activation patterns, hormonal treatments. Environmental non-modifiable risk factors can include what the players are doing, anatomical problems such as Q angles, knee valgus, the intercondylar knot size, that tibial slope angle. Those things can have a relationship and are difficult to adjust and prevent. And then once again, injury history, previous history of injury, age, those types of things. So looking back on our case study, we're kind of looking at some risk factors that this potential case could have had before the age of 20. So this person, they could have had a greater Q angle. They could have a lack of neuromuscular control. When they were landing from a jump, maybe if they had screened them, they would have saw that their knee moved inwards when they were landing. They could have had some increased joint laxity. They could have had some deficits in their range of motion and strength around the hip and the knee. Maybe, their ski binding dins were set really high. Maybe their skis kept on popping off while they were skiing. And so every time that happened, they just cranked up their dins with ski binding DINs is the pressure it takes to release the binding, especially when you're doing a fall. Maybe this person also had a slightly above average BMI, and maybe they had a narrow intercondylar notch width, and also environmental problem it could have been is before a ski race it could have just rained, and then it froze, so now the entire course was really icy. So then we're looking at what happened. Now we're looking at the inciting event. So so this person, has been training hard the last few weeks. She's been, she wants to improve her times, move up in the placing in the rankings. It's the last regular season race before the championship. It's her second run of the day. So, things being at the end of the season, training really hard, this person could be really fatigued and tired. Her muscles cannot really, maybe not adapt to the changes that are happening in her environment and at this level of competition. And because of the ice or rain the day before, there's ice around the gate. The person falls and she slides into some loose snow at the outer part of the course. Her tip of the ski catches and rotates her knee. She then, falls farther, and she hears a pop in her knee. Lots of pain, and then so ski patrol takes her down. She's sent to a doctor, and she's later is diagnosed with a torn ACL. So unfortunately, this, what kind of led up. So now we're going to look back at that disablement model. So now we're going to be talking about the origin, the organ, the person, the societal, and the environmental parts. So first, the origin, which is basically looking at the cellular level. So I'm going to be breaking this down kind of into multiple different parts, looking at what could have happened prior to the injury, what happened during and immediately after the injury, and then what's happening at each stage after the injury. So kind of breaking down every one of these parts before, during, or immediately after within the next couple of years, and then after the injury. So first, looking at the cellular level prior to an injury, maybe her muscle fibers and certain muscles were not strong enough for multiple different muscle groups. Maybe she had, a small injury, small fall, where she's had some damage in her surrounding structures or muscles, which are, predispose her to having another injury. Maybe also she has some ligament tissue laxity. And then, so the injury occurs, which causes damage to the ligament fibers. The force disrupts the fibers, and the blood vessels are broken, and then so the cells begin their repairing process. After the injury, maybe a few years later or immediately after, she has damage to the articular surfaces, the cartilage, kind of damage from the disrupting event, and from the change in her biomechanics. Osteoarthritis develops, and then also the surrounding tissue needs to adapt to the changes that the body has gone through. Those muscles and tissue at the ankle, knee, hip may all be making adjustments to account for not having an ACL or the surgery. Then we're looking at a little bit farther up at the organ or impairment body structure level. So, those muscle groups might have been a little fatigued. The person has an increased Q angle, the knee valgus, the notch size. Those things all could have are risk factors at this organ level that may have resulted in higher risk factors for the injury. And then during the injury, her knee rotated, causing the tearing of the ACL. After the injury, the patient could have, never fully recovered. Could have had some serious deficits in strength and range of motion. Maybe she didn't fully get, back into full extension or full flexion, or was, had some strength deficits. And so the muscle groups around it adjusted for the changes that need to happen. We're looking at the person level or the functional limitations activity level. So, this is when the screening part that you could see, maybe that the structures were not aligned while landing from the jump, or has some joint hypermobility. The person was fatigued really easily, or felt weak after practice, or they were overexerting themselves. All these things can kind of lead to some higher risk factors. And then, during the injury, the patient had pain with movement. That would be an example of a limitation at this level. And then after the injury, maybe they weren't able to ski or do the things that they want to do as long as they wanted to. Much later on in life, maybe they didn't feel confident skiing with their children on difficult trails. And then, every day after work, from working as a ski coach, they may have had some pain in their knee. So all parts of functional limitations. Now we're looking at societal level, which is the roles participation level. So this can be deficits, like for instance that maybe those neuromuscular imbalances or deficits that we talked about resulted in a lack of performance, and so because of this, in order to keep up with her role in society and the role in her team, she had to train more to improve her times and her abilities, which could have, because it might have been overexerting themselves, also led to injury. During injury, maybe she's not able to participate in sport for many months. She missed the championships. Maybe she can't drive to school or to work. If she was in school, maybe she had difficulty getting around to classes, having to wait for the elevator. Maybe, she had classes all the way across campus, and so she had to, she was always late to her next class. Maybe she doesn't feel part of the team because she can't practice and train. She has to sit in the lodge all day while everyone's up on the hill training and having fun. And maybe because of that, she felt like she needed to return to sport early, and she re-injures her knee. And then another thing that could kind of affect her is because of all this, because of how she feels with her role in her injury, she decides to retire from her sport because of pain and fear of re-injury. After injury, maybe she has difficulty demonstrating, proper technique to the athletes that she coaches. So because she's lacking some strength, stability, she's not able to show them how to turn properly. Maybe she has pain while walking up the stairs. She really likes going on long hikes, and she can't do that right now. Maybe as a ski coach, she's re-injured her knee a few times, or she's in pain every day, so she had to take unpaid leave from work because of surgery. And then also maybe she has some pain while she's kneeling and doing home improvement gardening projects, so she has trouble doing those things that she wants to do and needs to do for her house and her family. Next, we talk about environmental or social limitations. So prior to injury, maybe those neuromuscular and strength deficits may have caused, or fitness level, skill level, could have caused the coach to believe she was not trying hard enough or not listening to her instructions. So because of this, maybe she was overexerting herself or doing a lot of different things. During the injury, maybe she lost touch with teammates and coaches because she was separated from them. So she could have lost some friendships. The team lost the championship. Maybe she couldn't, over the summer she was rehabbing and trying to get stronger, and so maybe she wasn't able to do all the parts that she wanted, all the things that she wanted to do with her friends, like traveling, hiking, all the outside things she likes to do outside of skiing. After injury, she has difficulty completing her coaching job because of daily pain. Maybe she can't spend as much time, or she has to limit the family trips of going hiking or other family activities because of her knee pain and disability. And maybe another impact could be that she could warn her daughter about the high risks of skiing has on her future health because of her how the effect that her knee injuries have had on her life. So not only could this affect her life, but it can also affect others and their enjoyment of sport and activity. So we got to look back at the sports injury model. So the internal risk factors led to a predisposed athlete. So maybe those neuromuscular and strength deficits, anatomical differences, those types of things. She was exposed to an external risk factor, which caused a susceptible athlete. So that was like the ski equipment, the DINs being set up high, the ice from the environment and the rain, and then an inciting event led to the injury, such as the fall. So basically, who knows how many, if any, interventions had affected anything at these levels, like modifiable risk factors. If those have been intervened on, maybe the injury may have never happened, and all of the parts and pieces of the disablement model may have never affected this person and this person's life. So it's interesting to think about how many little pieces can lead to an injury and therefore lead to such changes in this person's life and their disabilities effect on their life. So kind of review. So as you can kind of see, things are very complicated. There's a lot of different parts. There's a lot of unknown. Who knows, how many of those intrinsic and extrinsic risk factors, if they had been modified in some way or another, what could have happened. That injury had a large effect on the patient's disablement model and their life and their health-related quality of life, kind of changed their role and society. But, disablement models, when we are treating patients, is crucial to think about and to learn about, so that way we make sure that we're treating the patient properly. Proper interventions could have maybe made reduce this disability happening, either after the first injury, if proper steps have been taken, like such as tertiary prevention methods, maybe this disability may not have ever happened. Also, another factor could have been a patient's lack of access to healthcare and cost of healthcare. That's always something to think about. A lot of times, especially in these skiing level, not many skiers have regular access to healthcare, except for kind of at the elite level. The ski patrol is there, and they have doctors and physicians that they see when things go wrong, but the prevention and regular rehabilitation is not part of that sport healthcare, unlike other sports such as football, where there's healthcare providers throughout many different skill levels. So it's important to have patient education. That also could have been an intervention that could have helped a lot. And also there was a lack of, maybe there was a lack of advocacy with the patient needs of the coaches and parents. So maybe if there was a healthcare professional that could have intervened and helped to understand with the coaches and the parents and the patient, help them understand what needed to be changed in that person's healthcare. So once again, we're looking at that primary, secondary, and tertiary prevention strategies. Primary prevention education on safety procedures, environmental concerns, and equipment. Those steps could have been helpful for this patient along with other patients. Secondary prevention methods, such as maybe if that patient had been screened for possible signs, could have led to an intervention and prevented this injury from happening. Tertiary, such as proper rehabilitation intervention before returning to sport for re-injury, could have also helped this patient greatly. And then patient education on the risk of returning to sport, and before, based on evidence-based practice, being able to explain that to the patient about what they should do based on the best evidence. So interventions that could have been helpful for this patient and others is having the proper access to healthcare, screening, proper patient education on both having risk factors and after an injury. Those are all could be helpful for understanding and creating prevention strategies. Prevention programs and using findings from the screenings in order to figure out what changes need to be made and what interventions need to be made. And also research is needed on all of what we talked about, and looking at that six steps of the TRIP model can be helpful to creating and reducing risk of injury. So the sports medicine team plays a crucial role in the disablement model and prevention. And the sports medicine team needs to be involved in the primary, secondary, and tertiary prevention methods in order to help patients with their disability and to prevent disabilities. The sports medicine team needs to be involved with research. They need to be involved with injury surveillance systems, collecting data together to understand where these injury mechanisms are coming from. And athletic trainers play a vital role in access to healthcare and relationship to prevention. They have a very unique relationship compared to other members of the sports medicine team because they're regularly employed and are in positions to have relationships with coaches. They spend a lot of time with their patients and athletes to be able to see the changes that need to be made. And maybe they could have intervened and created the proper steps that need to be made for prevention. Yeah. So here are the references. So just one thing I wanted to kind of overview is that we want to make sure that our prevention strategies go try and look at the intrinsic, extrinsic risk factors and try to adjust for the modifiable risk factors. So that way, when we have a inciting event such as a fall, such as this, it doesn't turn into a catastrophic injury like this. Instead, if we modify some of those risk factors, possibly we can have more people happy about skiing and doing the things that they enjoy. So thank you for taking the time to listen to me, And yeah, thank you.